procedures while we deal with the pelvic organ prolapse. And we'll have Dr. P.M. Gopinath, a legend by himself and a mentor to many obstetricians and gynecologists, introduce the speaker, Dr. Rajiv Verma. PMG sir, please.
Good afternoon, members. It has been a great pleasure having this meeting with you in spite of the COVID days. We had to schedule this meeting to meet the time between the UK and India at 5 p.m. Usually, normally we have it between 11 and 12. So because of that, we shifted now. We have a very eminent surgeon and a speaker and a very, very close friend of mine, Dr. Rajiv Verma. He graduated from Delhi, and then soon after his MBBS, he went to UK. He had various positions, and he's a very innovative surgeon. And besides that, he has been very keen on developing the medical instruments, like, he will be explaining to you about his innovations in a short thing. So we have done a lot of trials on that, and then now it's released, and then his company has been taken over by Cooper Surgicals in USA, and you will very soon get all his devices across the globe. So besides that, he's a very nice person, a good friend, a very loving teacher, and he would like to share all his secrets to you across the plate. So over to you, Rajiv. Thank you very much for accepting our invitation to be with us.
Thank you, Gopi. And, it is always a pleasure to talk to you. It's been a long time since we met. I think I remember we were there in October of 19, probably.
Correct.
And that is, we were hoping to start some kind of training program jointly with Harvard University at that time. But I think with the COVID striking, everything has been delayed. But hopefully that'll happen again. This is a very important subject for me, and I will describe my story. Let me just, sorry, the screen is, I'm going to try, because I can't see my own slides at the moment. It's all covered by all the pictures, all the photos. Okay, anyway, I think I can start now. So I think, as Gopi said, I left India as a very young graduate. I was 24, and I started my first job in a small hospital outside London. And I realized very quickly that this was a very special place. I was the only junior doctor, and there were two senior doctors, and they were just gynecology there. And I managed to do so much operating in my first 2 years of my training. I had virtually done every gynecological operation by the time I was 26, and it turned out to be such a good start to the whole long-term career. I did rest of my training as a gyne-oncologist, but then decided that gyne-oncology was not something I wanted to carry on for the rest of my life. And I took up a job as a urogynecologist just outside London as a consultant. And strangely, I ended up doing gyne-oncology as well because nobody else wanted to do it. So I've been doing that for the last 30 years. And I suppose the biggest thing for me is that as doctors or surgeons, we often do things because that's how we were taught. That's how everyone else does it. And we often don't question why are we doing this? And I think, this is probably the same answer applies here. Why do we do a hysterectomy? Because everyone does it, because we've always done it. And I think we just need to start questioning. And in fact, when you look at the data in the last few years, people have started looking at other options. And I think a lot of this talk is about my own journey of discovery in how to best manage uterine prolapse. And I'm one of those fortunate speakers that all the subjects I'm going to talk about today, I've done many of those operations. So I've not just read in the books, I've done multiple, because I've been experimenting as to what's the best way to deal with this problem. I will get on to the next slide. Right, so I will restrict myself to talking about level 1 prolapse, which is how Delancey has described, which is the prolapse of the vagina, the top of the vagina or the cervix, if the uterus is there. And I have believed for a long time that treatment of uterine prolapse really should be no different from treatment of a post-hysterectomy vaginal vault prolapse, which is what we seem to have been treating the two things separately. And I think so. The level 1 is the main support we are talking about here. I will restrict myself to that, and this is a very interesting. Delancey has done a lot of interesting work. So a lot of work, how we learned anatomy was to do with the cadavers. But I think the Delancey work, which is done based on MRI scanning, has shown different to what we've always believed. And you can see that the distal attachments of uterosacral ligaments occur, excuse me, in cervix and the vagina in large proportion of patients, and very few in vagina alone, and cervix alone in about 1/3 of the patients. But more importantly is the proximal insertion points, which are quite interesting, because you can see that I always kind of assumed, because we call it a uterosacral ligament, it goes from uterus to the sacrum. But you can see that it actually goes, in majority of the times, it goes to the sacrospinous ligament or the sacrospinous ligament coccygeal muscle complex, which is the same thing in 82% of the cases. And very, very small proportion actually go to sacrum. So the ligaments are not attached to sacrum; they are attached to the sacrospinous ligaments. And I think this is important in how we plan the treatment for the level 1 prolapse. So this is the MRI study. The right side picture is an enlargement of the box on the left. Uterosacral ligament is a mesentery-like structure which contains loose connective tissue, smooth muscle, blood vessels, and autonomic nerve fibers. Uterosacral ligament has more nerve content than cardinal ligaments. And the superficial part contains mainly of smooth muscles and peritoneal connective tissue. The deep part is mainly nerve fibers. Excuse me. So the authors here, this work is all done by Delancey. They have been studying uterosacral ligaments in cadavers for a long time and at surgery. But they've realized that when they started doing MRI scans in live patients, it changed the way they looked at it. The borders of the ligaments are very, very difficult to establish when you are dissecting the ligament, even in live subjects. And in cadavers, it's even more difficult. So they often think that the dissection of the ligament is somewhat arbitrary. It's not that easily identified. So when they started doing MRI scans, they saw that uterosacral ligament was visible in 90% of the scanning. So it was much easier to see. And the length of uterosacral ligaments was much smaller. So the average length of a uterosacral ligament was about 2.5 centimeters. The range was from 1 to 5 centimeters. So they are very, very short ligaments. Next slide. So what do we want to do when we see a patient with prolapse? These are very obvious things. We want best clinical outcomes, which are anatomical, functional, and of course, the patient satisfaction. We want to do a procedure which has lowest morbidity, and we want to do a procedure where a patient recovers quickly and spends least time in the hospital. And I think all these factors are very important. And particularly, we tend now to see, I don't know what the practice in India is like. I see younger and younger patients. 30 years ago, it seemed to be that a lot of our patients' average age would be 65 plus. But now I see patients in their 40s who come along and say, we have a problem, what can you do? And these patients pose a difficult problem because they have different lifestyles, they are more active, they are exercising, and it becomes more challenging to treat these patients. And these patients also seem to become more and more aware of their physical appearance of the prolapse. And so you got to manage their expectations, which can be difficult. We know that we see patients sometimes in our clinics, and you all know this, who come to see us for a completely different reason. And when you examine them, you'll find that they have a significant prolapse. And you often see patients who are having a hysteroscopy that you can pull the cervix down to almost outside the introitus, yet those patients have no symptoms when you ask them about the prolapse. And it's those patients where, do you even tell them? And I have to admit that I sometimes say to these people, look, you have a mild prolapse, but it's not bothering you, and we don't need to do anything. But so prolapse is quite interesting in some ways, that patients who have significant prolapse sometimes are completely without symptoms. And yet you see others who are bothered by a mild degree of prolapse. So, and we know it's a common problem. This is a study from Oxford, which shows a lifetime risk of 11% of having a procedure. And we also know that a significant number of these patients will end up having a repeat operation. And as I said earlier, there is no current definition of pathological prolapse, which is clinically valid. 5 to 6% of asymptomatic patients demonstrate prolapse. I think it's probably even higher than that. And the incidence is possibly growing. Next slide. So my interest in vaginal surgery goes back some years. I got appointed as a consultant in 1992 to a small hospital where there were three of us, three senior gynecologists, and we had registrars and junior doctors. And I was at that time, like anyone else, doing abdominal hysterectomies for people who came to see us for menorrhagia, dysfunctional bleeding, small fibroids. In 1994, I made an effort to try and convert all these operations to vaginal hysterectomies. And we published this in the Green Journal in 2001. And this was a series of about 550 odd cases. So when I started in 1994, I was probably doing about 25% vaginally and 75% abdominally. By the fifth year, I was doing 95% vaginally, even bilateral salpingo-oophorectomies. So it just shows that just by changing what you want to do, you can achieve that. And we know that vaginal hysterectomy is cheaper. Patients stay longer and less time in the hospital. There's less post-operative pain. They return to normal activities early, and they have lower complication rates. And there is no doubt about that. So at the end of our 5 years, our conclusions in that study was that the major determinant of the route of hysterectomy is not the clinical situation, but the attitude of surgeon. And we were doing hysterectomies on women who have not had any children, with enlarged uteruses up to 16 weeks, previous 2 or 3 cesarean sections. And the route of the hysterectomy, as I say, can be changed from abdominal to vaginal just by the willingness to do so. There is no need for extra training. You don't need any special skills or expensive equipment. And there is no increase during the time of the study of 5 years, there was no increase in patient morbidity. We had only 2 patients where we had converted from vaginal to abdominal hysterectomy. And we felt that widespread use of this approach would have a big impact on healthcare resources. 20 years from now, I don't think much has changed. There are pockets of doctors who are doing this, but majority of the people are still doing abdominal hysterectomy. And of course, the laparoscopic hysterectomies have come along and changed the practice somewhat. So at that time, interestingly, what I was doing was I was doing hysterectomies vaginally for women who came to see me for non-prolapse uteruses. And I also realized that when we were doing hysterectomies for prolapse vaginally, the outcomes were not very good. You know, all of us have seen people who would have a vaginal hysterectomy and repair and come back fairly quickly afterwards with a vault prolapse. So I started doing abdominal hysterectomies for prolapse, and I'll explain to you why. Because what we were doing at that time, sorry, I'm going to the next. So this was my practice in 1995 to 2000. I was either doing SACROCOLPOPEXY abdominally without a hysterectomy, or with hysterectomy, or most commonly with subtotal hysterectomy. I found that that was probably giving the best outcomes. But of course, there are problems with abdominal SACROCOLPOPEXY. These patients are often obese, they have other morbidity factors, and of course, the length of the stay. And anatomically, I was always slightly uncomfortable because you are pulling the vagina to a completely different angle. But that was my opinion on this. So for 5 years, I did this procedure, and I was constantly looking to find a better way to do this, solve this problem. And of course, I mean, people are now doing laparoscopic sacrohysteropexys. I don't know how many of you do this procedure, but it's not a procedure I have attempted to perform. But again, my issue with this is the morbidity and the anatomical correctness of the angle of the vagina following the operation. So at that time, what was the other option? Sacrospinous fixation was an operation which one could do. The instruments at that time were quite tedious, and the procedure involved a lot of dissection and just was more complex than it should have been. People were also doing uterosacral ligament suspension, and I personally think that procedure was quite useless because these uterosacral ligaments, as I said, are very hard to identify. Secondly, they are already elongated in patients who have prolapse, so suspending the vaginal vault with the uterosacral ligaments was not a great answer. And then in 1999, I was at a conference. I used to travel to conferences, often wanting to meet people who are doing similar things. And I think this was in Argentina. I met Dr. PETROS, who was from Australia, and he gave a presentation about posterior IVS. I don't know whether any of you have come across this. After his presentation, I caught up with him and I said, look, I would like to learn this operation. And he said, oh, come to Australia anytime. I said, well, it's too far to come. So he put me in touch with a professor from Paris. And as soon as I came back, I emailed him and I said, look, I would like to come and learn from you. And he said, oh, just come anytime you want. And I went to see him. I think it was probably August 1999. I went to watch him and he made me assist a few procedures. I went there for 3 days. I came back to England, and in 3 months, I had done around 40 operations. And when I told him, he said, oh, that's more than I have done. But I think it was a clever operation. There were issues with that, which I will discuss. This operation was done through 2 small incisions, about 3 or 4 centimeters from the anus. And you had to put the needle through the ischiorectal fossa, and then you pull that needle out through the sacrospinous ligament or the coccygeus muscle, and took it out through an incision in the vagina. And through that, you threaded a tape which came out on either side, and you attached the tape to the cervix or the vagina. The problem when they first started doing this procedure was that this tape was a multifilament tape, so that the tape erosion became a big problem. They eventually changed over to a monofilament tape, which was better. But I think the problems with the first tape put that procedure into disrepute, so people kind of stopped doing it. But I think this was quite a good operation. And obviously at that time, there were other developments going on. I was initially involved with the TVTO development in 2004 with Johnson & Johnson and did some cadaver studies. And they were at that time developing meshes for prolapse repairs as well. So I'm just going through the history, and I think going back a bit further, TVT came along in 1999, and I assume that a lot of people are doing TVTs in India. I did about 1,200 or more than 1,200 of these operations after going to learn it from the surgeons in Sweden. I probably was one of the first doctors to do it in UK. And I think the mesh use for prolapse originated from this, and partly mesh used in hernia repairs. I started because the posterior IVS, the PETROS operation, that instrument disappeared. So I was trying to make other instruments suitable to try and do the posterior sling to support the uterus or the vagina. I can tell you that looking back from 2000 and probably as early as 2000 till now, I have not done a single hysterectomy for uterine prolapse, except in people who had other pathology. But majority of the patients who turn up to see you with uterine prolapse actually do not have any other pathology. So I have virtually given up doing hysterectomies for uterine prolapse. But there were other meshes, and as you know, the meshes have now been taken off the market. In UK, in fact, unfortunately, we can't even do a TVT for the moment. There is a moratorium on that, which is a shame, because I now have a lot of patients with incontinence, and we don't have a good way to treat them because we can't do TVTs. So, I mean, I don't know whether any of you have had experience using the ProLift. I think I had been to India and shown this procedure in a couple of hospitals many years ago in the early stages. And I think there were problems with mesh. And I think the problems were that the meshes were too large. The procedures were more complex. So the gynecologists were not used to doing these procedures in their routine practices. So they had to completely learn a new technique. The anatomy of the pelvic floor was not something a lot of people were comfortable with. So a lot of these procedures had other problems with it. It wasn't just the mesh which was to blame. It was the technical difficulty in performing these. Sorry, I'm just going to go off. Yeah, so I think these were the problems. I think my guess is a lot of problems were the people who were using it. Procedures were unlike what most gynecologists were used to doing. More anatomical knowledge was required. And I also think that industry obviously wanted to promote it. They wanted as many people to do it as possible. And a lot of people started doing it, and the complications obviously then led to the problems with the mesh. So at that time, people obviously started using meshes to treat uterine prolapse. And this is a study of 175 women where was a randomized trial, and they found that there was no real difference between the two groups. The adverse events, of course, in the mesh exposure, a mesh group was the exposure of the mesh versus no exposure in the other group. But I personally think that this procedure done correctly has a very high success rate, and possibly a lot simpler than performing a vaginal hysterectomy. Now, this is a procedure I used for last, I'm trying to now go back, and probably from 2005 to 2015, for 10 years, I was using this procedure. This is a procedure which allows you to place a mesh without making any incisions externally. So it's a single incision procedure, and the mesh can be cut into a very thin strip, and you can attach it to the sacrospinous ligaments bilaterally and attach it to the cervix or top of the vagina. This procedure is quick. It takes probably no more than 10-15 minutes to do. and majority of the patients, and I would say 99% of the patients would go home the same day within a few hours of having their operation. And I have some data on that, which we have presented in the past. And I also think with the mesh, one of the issues was any of us who do vaginal surgery know that the connective tissue between the bladder and the vagina and the connective tissue between vagina and the rectum is somewhat different. There is more loose connective tissue posteriorly, and placing a mesh posteriorly is a lot simpler. So you get very, very few erosions into the vagina. And I still believe, despite the fact that we don't have mesh, the best procedure to suspend the vaginal vault or the cervix is to attach it to sacrospinous ligament through a single posterior wall incision, which is probably the best operation. Unfortunately, I don't think we will get a chance to do this procedure again because we have no instruments left. No meshes are being sold, and I suspect India can't be much different. So what do we do? So we can do sacrospinous fixation with a single incision. You can do a unilateral sacrospinous fixation or bilateral. And this is using a permanent suture, not a dissolvable stitch. You can do abdominal sacrohysteropexy, or you can do a laparoscopic sacrohysteropexy. I still believe that performing it vaginally gives the best anatomical results. But I do think that abdominal sacrohysteropexy and laparoscopic sacrohysteropexy do have a role. So that instrument now is also available without a mesh. So you can use a suture, which allows you to insert the suture through a single incision in the posterior wall to the sacrospinous ligament. You can use it on both sides. I often use it do it bilaterally. And it produces a very good, the moment you do the procedure, you can see how it pulls up the uterus to its normal position. There are other instruments available. I don't know whether this one is available in India, but they're all very similar instruments. They are single use, and some of them are very expensive. And I think that's the challenge, particularly Indian government hospitals. Whether they allow you to buy those instruments is probably going to be a problem. So this is a more recent study, which sacrospinous hysteropexy versus vaginal hysterectomy. And you can see that in this group, there were no differences in the two groups of patients. Vaginal hysterectomy was associated with 3 times higher risk for urgent incontinence. And I think that's probably because you have to dissect the bladder off the cervix, which causes the bladder problems. But the procedure is equally successful. I think there's another study. This is the more recent one, which was published in the British Medical Journal. This was a randomized trial of 208 patients. And you can see that the risk of recurrence after carrying out a sacrospinous hysteropexy was 1%, and after vaginal hysterectomy was about 8%. So there was a significant difference in outcomes in terms of success. Now I had a video which was made a few years ago, which I have been trying to find, and I have been able to locate it. But if I find the video, I will give it to Gopi and he can pass it on to everyone. It just shows how simple the procedure is. This procedure will typically take me about 10 minutes to do. And these patients come back to the ward. Majority of these patients have very little pain. Some patients do get some pain, particularly around the buttocks area. And that is probably due to bruising around the uterosacral ligament, around the sacrospinous ligament. But most of this pain disappears within 2 weeks. I have yet to have anyone who's had long-term problems with sacrospinous fixation. And I think these are sort of certain things we think people get a lot of post-op pain after vaginal surgery, the need for catheter, We published our first series of about 80 patients a few years ago when we started to operate on all our prolapse patients as day cases. So whether it's anterior repair, posterior repair, both together, or with sacrospinous fixation, none of these patients spend more than 4 or 5 hours in the hospital. And this was the pain scores. So you can see majority of these patients had a very low pain scores after having surgery to keep the uterus intact. So you can see 70% of the patients had pain scores on visual analog score of 0 to 2. Now, this is something this is a technique we I haven't mentioned. It's a technique which it's worth talking about while I'm discussing this. We still see patients with very large prolapses in UK, so it's not confined to India. I know a lot of patients in India will not come to the hospital because they're too scared to have anything done or too embarrassed. But even here, we see patients who will come with a very large prolapse. And another one with PROCIDENTIA. These patients are very difficult to deal with. The problem is the tissues become very poor. They are keratinized because they've been sitting outside. Dissection can become very difficult and bloody. And in the past, I remember we used to admit these patients to put packs inside the vagina to keep the uterus up for a few days before doing surgery. And often these patients are poor surgical risk and they are obese. We described a technique which over the years I've used many times now, and I think it's something I would recommend you all to try it because it's a very simple technique. All you have to do is when you see a patient with such a large prolapse, you bring them into the hospital, and even under local anesthetic, you can carry out a very tight perineorrhaphy. So you are making the opening of the vagina small because often you can't put a ring pessary in these patients because it falls out. So if you can replace the prolapse and perform a tight perineorrhaphy and put a large ring pessary inside, and then send them home, and you see them back after 3 months and remove the pessary and see how they are. And we did we presented we published 5 cases like this in our own practice. And I remember they became so much easier to operate. One of the patients, in fact, was so much better that she didn't really want an operation. So we just managed her with the ring pessary. But over the years, I've done a few more of these operations. Every so often you see a patient with a large PROCIDENTIA, and I believe this is the best technique to use. It's not been described in any of the books, but this paper got lost in a small journal many years ago. Well, 12 years ago now. I haven't met many people who've tried this technique, but I would highly recommend that people who are dealing with the prolapse should be using this. Now, will the meshes ever come back? The answer probably is unlikely. Industry plays a big role in this, and I think they are still dealing with the fallout from the previous mesh debacle. So it's unlikely that they will start making any more meshes in the market. But I hope that we'll have newer materials because the native tissue repair still has significant limitations. We haven't really found the best way to carry out repairs, particularly in younger patients who want to have a normal sexual function. It's easier if you see an 85-year-old, you can do procedures and do a very tight repair. But the young patients have got a lifestyle which they want to be out, they want to be doing things. Some of them have young children, they are lifting them. So all these things are a big challenge. And the native tissue repair does not really work very well in these patients. And I think the vaginal suspension procedures work extremely well without having to remove the uterus. I really, as I said to you, I have not done a hysterectomy for almost 20 years. You can see there are randomized trials which show similar results. The morbidity is less. These can be done as day cases. and these patients will recover very, very quickly and return to normal. And as I said to you, I don't put catheters in these patients because 99% of them void successfully without any problems. So it's a procedure worth bringing back, particularly the sacrospinous fixation for people who were doing it many years ago and stopped doing it, because there are better instruments which allow you to do sacrospinous fixation with minimally invasive techniques. I don't know what multi-use instruments are available in India, but I remember those previous needles we used to use were quite large needles, and they made the dissection much more difficult, whereas the newer needles are much, much easier to use. I think that is, I'm finished here. Happy to take questions. See if I can. Are you going to put
Thanks,
questions?
Rajiv. Thank you. Thank you for taking us through the journey. You will remember we conducted a workshop live on the posterior tapes with about 6 patients in Surya Hospital, Chennai.
Yes.
And all of them have been doing well. One is a consultant gynecologist now.
I
practicing.
remember. Yes, I remember she was very young when we operated on her. Yes, yes.
So it has been doing. The same thing, I just took the clue and I was just trying to do it in my unit in Government Kasturba Gandhi Hospital. There, what I used to do, in the absence of the mesh and other things, I was using an umbilical cotton tape, which will be covered with a small betadine ointment for the lubrication. And I have used it at least more than 20 patients, and none of them have come back with any erosions or side. Those people who have worked with me in that hospital were appreciative. I think you have also visited that hospital one day and we have showed you.
Yes, yes,
with
I
Korean
remember that.
around.
Yes. Yeah, it's I think the problem there is a problem with sacrospinous fixation. If you make it too tight, the vagina, the level 1 vagina is a mobile structure. It should not be fixed to the sacrum, which is all these sacrospinous ligament, which is what a lot of people were doing. They were making it very tight and tying the stitches very tight. You have to leave them very, very loose. You have to make sure that there are 3 or 4 centimeters between the cervix and the sacrospinous ligament, so that it is mobile. And that is when they get less pain. And pain is because if you make a very tight stitch, they get a lot of post-op pain. And also the stitches tend to cut through. Whereas if you leave it loose, the success rate is much, much higher and there is very little post-op pain.
Srikala, any questions from this?
Yes, sir. Rajiv Verma ji, sir. Do you do a bilateral sacrospinous fixation when you do a uterine preservation procedure, or do you do unilateral? That is number 1. And do you use a proline and anchor it from within, or you prefer to use a PDS and bring it out?
So, right. The first question about bilateral, in fact, most of the studies are unilateral, but I often do bilateral, particularly if the prolapse is quite bad. And I use proline. I tend to use a fine proline, a 2O proline, which works extremely well. The only trouble with proline and PDS is that the tying is very difficult because the knots slip. So you have to be careful to make sure that the knots don't slip, but they work extremely well.
Do you combine any cervical amputation?
Yes, absolutely. Yes, I meant to mention that in my talk. I think a lot of these patients have elongated cervix. And I mean, this is going back to the old Manchester repair, which we used to learn as medical students. And I think removing cervix makes a big difference in some patients. You don't need to remove it in every patient, but if they have a long cervix or a bulky cervix, removing it makes it, the outcomes are so much better.
Maybe if it is a lady who desires conception, fertility, then
Yes.
you may change your option.
Yes, of course. Yes, you don't want to remove the cervix if they. But you know, I
Elongate
really
cervix.
tend to operate on women when they've completed their family. Very few, we see very few who come to have an operation because, you know, if they're going to have another baby, the procedure is not going to work, you know, the moment they fall pregnant and carry another baby. So we tend to avoid operating on women who are planning to have babies. But no, you're right. Occasionally you will see a patient where you don't want to remove that cervix. Yes.
So what is your plan on, say, a para one, living one, 30, 32 years, who wants to conceive and deliver? She's had previous vaginal deliveries. She's interested. So what is and she has a third degree. It is about, say, 4 to 5 centimeters out of the introitus.
Yeah, I mean, this procedure works extremely well. I wish we still have meshes, because I do think meshes have the highest success rate in the long run. I mean, I still see patients. In fact, I saw a patient in my clinic just 2 days ago who I had done a mesh repair about 10 years ago, and her cervix is still minus 7 centimeters. So I think they work very well, but sutures obviously have limitations. They can cut through, particularly when they fall pregnant and there's a lot of pressure. But no, that is the right operation to do a sacrospinous fixation bilaterally.
What is the role of abdominal sacrocolpopexy suspension or abdominal hysteropexy in them?
I mean, I think it's a successful operation. It's just a more morbid operation. It's it's
Fan and steel laparotomy.
I think so. I mean, I did many of those in the early days, but I just felt that, you know, once we started using the meshes posteriorly or the sacrospinous fixation, I really don't think there's a need for it. But occasionally, you know, if it fails, then you might have no option but to do it abdominal or laparoscopic sacrohysteropexies.
But you no longer do any mesh procedures vaginally, no?
So the meshes are not available in the market anymore, which is a shame, because I think used selectively and carefully in the right hands, they were a good procedure. The meshes probably needed to be improved, but there were better meshes coming along. But I think the litigation has been such a big problem that I don't think any device company is going to touch meshes again, not for prolapse anyway. Yes, because there is also litigation at the moment going on for meshes for hernia repairs. Even they have had difficulties. I mean, it's a foreign body, and some people will react abnormally to it.
Have you tried any autologous facial slings? Like we do for stress urinary incontinence, we routinely take a rectus facial sling. We don't prefer tensor facial letter. Like that,
No.
do you use any for uterine preservation procedures?
No, I haven't. No, but I mean, for incontinence, many years ago, I used to do them, but I have now gone back to doing STEMIs operations for stress incontinence. I now do a STEMI procedure, which obviously does not involve using a mesh, but you can use a Prolene stitch and try to support the mid-urethra. So I've kind of modified the STEMIs procedure to do that.
Ajit, can you ask your question, please? Unmute.
All right.
Unmute.
Yeah, okay. Dr. Verma, it was an excellent presentation. I am Dr. Ajit Wasi. I'm the lone man out in the field of gynecology because I'm primarily a urologist with a huge interest in urogynecology.
Oh, nice. Okay.
And we have had a huge amount of experience of sacrospinous, both bilateral sacrospinous. And what I do in a very simple way, that 3 Nebritsky's retractors.
Yes.
When you see that, it is very important for every student of mine.
Yes.
That we have to tell them what is a sacrospinous fixation.
Yes.
Because most of the time, the coccygeus muscle covers the entire sacrospinous fixation.
Absolutely,
And
yes.
unless from lateral to medial, you go on dissecting it few times, you will never get those shiny fibers. It is also important, even in urology, I take a large amount of clinics for our urology students who are interested in female urology to show them what is the ideal place, namely the 2 centimeter medial, and what are the different possible this thing. But what I do here is, because I have a few KPO devices, but the trouble of KPO devices in India is that we don't get a regular and classical supply of half needle which are inducted inside. That is the problem. So every time I go to Dr. Chris Chappell, I get few things, or to United States or something. It's like beg and borrow policy.
Yeah, I think I am surprised. I have often thought that we should be able to make a reusable needle to be able to throw these stitches, because, you know, I think the dissection to see sacrospinous ligaments is not required.
I agree with you.
That dissection often causes bleeding.
Correct. And between the 2 fingers, you can put a KPO device and quickly maneuver that. And in less than 10 minutes, the procedure is over.
Exactly.
But here, you have to demonstrate it for 15 to 20 minutes and thereafter take sutures.
I have some ideas to develop a multi-use needle. So maybe one day I shall send you that.
All right. Whenever I come to England, I will call you.
Oh, please. Yes.
And we will have a lot of this thing. And if you can give us or send us a few supplies, I will provide 1 KPO device to Professor Dr. Sheila Prasad, because I have more than 6 or 7 just lying there without ammunition. What is the point in having a gun without ammunition?
So true. So true. Yes. Now, the KPO device is very, very good. It's very clever, but unless you have the stitch, you can't use it. It's useless for you. And they, I don't even know. They probably are very expensive. I have no idea how much they cost, because I just use it in the hospital. We just get it for nothing.
No, but it's very expensive. Believe me or not.
Yeah, I can imagine that.
For 10 sutures, you have to pay $110 US.
Oh, right. So expensive. Yes. Oh, I should be able to get hold of some sutures for you.
Second question, last question I wanted to ask you. There is a huge amount of debate all over the world. When you do a good quick suture at the sacrospinous, where is the ultimate stitch comes in, especially when you're doing a uterus preservation surgery? Is it on one side or is it on both the sides, so that you can push in the entire cervix, gives you almost a near normal or a midline stabilization of the cervical cervix?
I think I started off doing bilateral.
Yes.
But I think I've also realized that as long as you don't stitch it too tightly, if you leave good 3 or 4 centimeters between the sacrospinous ligament and the cervix,
true,
unilateral works pretty well. True. But you have to make sure that you take deep sutures through the cervix, otherwise it cuts through. And also, if it is loose, it is less likely to cut through. So you don't make it too tight. So I don't think there's any clinical evidence one works better than the other. But as I say, I did start using initially bilaterally, but then I feel that unilateral works equally well.
Thank you very much. It was lovely meeting you. Dr. Professor Gopinath and Professor
Thank you.
Dr.
Thank you.
Shrikala, thank you very much for inducting.
Sir.
There is one Professor Dr. Paili from South India, Rajiv. So, he's from Kerala. He has devised a small Mia needles where it is reusable and it is very practical and very simple.
Yeah, because Mia hook was too big. It was just needed too much dissection. And if somebody has created something like that, yeah, it's excellent. But I still think that, you know, you can make the smaller the needle, the better it is, because it just makes the dissection less complicated. And you don't need to see the ligament, you just need to feel it, and because
That's right.
try to see the ligament means that you are dissecting and you're making them bleed. It just takes so much longer time. Oh, I'd like to see that instrument, if somebody can send me some pictures.
We improvise with the long 12-inch needle holder, long needle holder.
I know.
But use a navratil Brisky retractor and again a 1-inch retractor above. Try and visualize, but that involves a good dissection.
I know.
We need to have a dissection in the right plane, and we don't unnecessarily damage any vessels. We are able to feel the ischial spine, then keep 2 fingers, and then take a bite. We take a pulley stitch with the 1 proline and anchor within the vagina. That's how
do you use hydrodissection? Because you have you need to,
I use xylocaine adrenaline pre-mixed vials if the patient has no comorbids. If the patient has any comorbid, I use plain normal saline, sterile normal saline, which is really very useful, so that when you open in the midline, you're able to go nicely into the plane. You mobilize the rectum, just perforate the rectal pillars. You are onto the ischial spine. Then try to feel the ischial spine. I just have a specially designed long needle holder, and with that, with the navratil Brisky retractor, another 1-inch retractor above. That we are able to do.
I know, but I still think because the sacrospinous ligaments are facing you sort of flat, it's harder to put a stitch through unless you see it clearly. So so the dissection can be avoided if you have the right tools, which you're just making do with whatever you have, I suppose.
Do you prefer? I'm little scared of high uterosacral suspension because of the possible inadvertent ureteric injury. So I don't do much of a high uterus. I'm a fan of sacrospinous. What is your take in that, sir?
I think uterosacral ligament suspension is not an operation which you need to do. If you can do a safer operation, which is more successful, uterosacral ligaments really are already damaged in these patients. So yes, no, I don't. Many years since I stopped doing it.
That's really nice. Any other carry home message you would like to tell our budding gynecologists and the practicing gynecologists?
Yeah, I mean, I think, I remember a lot of my junior doctors used to come and say, oh, we want to learn to do a vaginal hysterectomy, and you're not doing any for prolapse. But so I said, well, I'm doing plenty for, dysfunctional bleeding. So you learn that. I think that is an operation which people need to learn again, because for dysfunctional bleeding or small fibroids, people need to be doing vaginal hysterectomies. Why do you need to use a laparoscope and expensive instruments and robots and whatever else they do? Because, with the right skills, that operation again takes no more than 20 minutes, half an hour, and the patients can go home within 24 hours. So you need to teach people how to do vaginal hysterectomies without prolapse.
Yes, Rikla.
Yes, sir. I think we are almost in time. I think if there are no other questions, we are on time, and we can close the schedule. So I take this opportunity to thank our faculty from our international faculty, Dr. Rajiv Verma, the man behind the scene, Professor Gopinath, and Dr. Ajit Vase, who has been kind enough to join us. And he has always been our support whenever we organize any function, even in KGH, he used to come. We sincerely thank all the delegates who have participated, even though it is on a Sunday evening. I thank Balaji and the Shield Pharma for having sponsored this. And we will again meet during the next monthly webinar. Dr. Gopinath, sir, have you...
We have yet to formalize the thing. We are most welcome if someone else comes to conduct it. Otherwise, we'll plan very soon and let you know.
Yes.
Thank you. Thank you, Rajiv. Thank you, sir.
We'll speak soon.
We'll catch up to you. Bye-bye.
Bye-bye.
Thank
Bye.
you.
Thank you, sir. Thank you, Verma, sir. Thank you,
Thank you.
Gopinath, sir.
Thank
Thank you,
you.
ma'am. Yes.